but I do participate on various advisory boards, just in terms of how novel medications are implemented or are used across the country. And so I participated in ad boards with Pfizer, AbbVie, and Taiho Pharma. And the purpose of the talk today, so I wanted to talk a little bit about MDS diagnosis and risk stratification, because there's been some changes in terms of how we risk stratify people over the past few months. I wanted to just very briefly touch on current management strategies for people who have MDS. And then I wanted to primarily focus on some novel and emerging therapies that will hopefully improve outcomes for people who are experiencing MDS. So the diagnosis of MDS can be a tricky one to make, but essentially what MDS is a bone marrow condition that affects the bone marrow's ability to make healthy blood cells. And so most commonly it happens as we get older. And as a result of this, our bone marrow is our blood factory. And so if our bone marrow isn't functioning properly, then people can sometimes experience issues related to low blood counts. And if you go to clinic, sometimes we talk about cytopenias, which is really just a fancy word of saying low blood counts. And the three main blood counts that we often are talking about in reference to this is a low hemoglobin level. And when people have low hemoglobins, they can sometimes experience fatigue or tiredness. And depending on the numbers and how they're doing, they may or may not require blood transfusion support. We talk about low white blood cell counts, and those are part of our bone marrow that are very helpful to our immune system, and they help us fight infections. And we talk about low platelets, and platelets are really needed to help us prevent bleeding. And so when we see a pattern of low blood counts for one reason or another, it begs the question of, is there something going on in the bone marrow that is inhibiting the marrow's ability to make these cells as it typically does? And so there's some clues that we can use on peripheral blood to suggest a diagnosis of MDS, but the true diagnosis really does require a bone marrow biopsy, which is often to patients' dismay because nobody wants a bone marrow. But based on this bone marrow biopsy, that it's very helpful because A, it allows us to make a diagnosis, and B, it allows us to risk stratify what type of MDS a particular patient has, because as I'll allude to later, MDS is really a spectrum of disease, and it can really affect people in very different ways. So to have a diagnosis of MDS, you do have to have low blood counts, whether that's one blood count or multiple blood counts. It doesn't matter, but you do need to have low blood counts. And then based on the bone marrow biopsy, you have to have one of these three features. And I won't go into it in too much detail, but either the cells have to look atypical under the microscope when we look at the bone marrow. Sometimes we make the diagnosis because people have increased bone marrow blasts, and blasts are immature cells that divide and populate the bone marrow, but the number of blasts is tightly regulated. So when it's too high, that can sometimes suggest that there's a problem going on in the bone marrow, or we find that there's genetic abnormalities in the bone marrow cells. And so because MDS is a spectrum, it can behave very differently from one person to the other. And it's very important that we are able to risk stratify so that we can really talk with our patients to explain, where things are at and what we can do to try and keep them in the best state of health that we can. And some people will have a very low risk type of MDS that can remain stable and kind of indolent for prolonged periods of times. Whereas other patients can sometimes have a higher risk disease that can sometimes behave a bit more similarly to AML. And so in clinic, we will often apply risk stratification scores to the diagnostic tests that we have so that we can best stratify patients with MDS into a lower versus a higher risk type of situation. And so the scoring that we used to use up until probably even June of this year was the IPSS R score, which looks at, what the blood counts are doing, and it looks at various different results from the bone marrow biopsy. And then it would kind of risk stratify people into the very low to very high risk score. But in June of this year, the IPSS-M, which M stands for molecular, came out, and it kind of builds on the IPSS-R, but it allows us to use results from very kind of specialized genetic testing, and it allows us to further kind of predict how a given MDS might behave in a particular patient based on some of the genetic test results that we have available. So it's kind of a better prediction tool on something that we're going to see is used much more commonly moving forward across Canada and throughout the world. So this is just a very quick output for people who might not have seen it, but you can't calculate the IPSS-M yourself. You need to go online and use a risk calculator because it's based on a model, so it's quite complicated. But you put in people's blood results in terms of their blood counts. You put in results from their bone marrow about their blasts and their cytogenetic abnormalities. And then you can put in a number of different gene mutations, whether those are present or absent. And then it'll spit out a different summary based on those, low risk score, what the IPSS-M is, what the IPSS-R is, and then how that the different variables kind of relate to an overall cohort. And recognizing that these numbers kind of apply to a population, they don't always apply to one individual patient, but they can sometimes help frame the discussion and help kind of communicate where things are at and what we might expect for given patients. And so in terms of MDS treatment, there's a lot of variability in terms of what we do and what we need to do. And the bottom line is that it really depends on the risk status of that given MDS. And so in people who have lower risk disease, the goal of treatment is really to improve symptoms. Sometimes it's to try and reduce the need for red blood cell transfusion or transfusion dependence. And we want to try and maintain quality of life as best we can. Whereas in higher risk disease, where the trajectory of the disease is sometimes different and the tempo can sometimes be accelerated, the goal in our clinic is to improve survival, but we also want to improve symptoms and maintain quality of life as best we can. And so treatments can really vary by intensity. And so here is just a very quick, it's not a very fancy slide, but if you look here, it can just show how on one hand, in some patients with low risk disease and very mild changes in the blood counts, observation is totally appropriate. In other patients with lower risk. Just give me 1 second here.
If everybody could mute themselves, so we're getting a little bit of that's perfect. Thank you.
If the blood counts, in particularly the hemoglobin, are going down, sometimes we use erythropoietin stimulating agents to try and boost that red blood cell count. And then, the number of treatments that we have available to us can vary depending on how the disease is presenting, what patients' preferences and wishes are, and what we're seeing on blood work and on bone marrow results. So this is perhaps an oversimplification, but this is some of the frontline treatments that we're currently using in patients who have lower risk MDS. And so we'll go through each of these just very quickly, and then we'll focus on higher risk MDS, and then lastly on some of the novel clinical trials that are coming out. So one of the mainstay treatments in MDS is red blood cell transfusion support. Now, that doesn't mean everybody will require a transfusion, but transfusions are particularly helpful for people who have low hemoglobin levels. And so I kind of think of transfusion support as a way to kind of top up the body and fill the tank when the body is unable to kind of fill the tank itself. And so they're used relatively frequently. Blood transfusions, the need for transfusions varies, and it can vary depending on what the blood work shows, and it can also vary on someone's health and how they're feeling and how the low hemoglobin is affecting them. And so from one person to the other, the need for transfusion can also vary. Some people might need weekly blood transfusions, some people might require monthly blood transfusions, and some people only require very infrequent transfusions. So there's really not a broadly applicable strategy to transfusion support, but it's definitely something that can be part of the mainstay of treatment for MDS, particularly in lower risk patients. Erythropoietin stimulating agents are kind of an adjunct that are commonly used in MDS to try and prevent transfusion dependence or the need for blood transfusions. So our body makes EPO, which is kind of a short word for erythropoietin. And EPO is a stimulant for our bone marrow that stimulates our bone marrow to make more blood cells. And so in MDS, a number of years ago, kind of early in the 2000s, we realized that in patients who have low blood counts and myelodysplastic syndrome, by giving them extra EPO, we can often stimulate the bone marrow to make enough blood cells that they may or may not require blood transfusion support. And if it works, this is often preferable because it's a lot easier to give an injection than it is to give a blood transfusion. And so there's less time spent in treatment rooms and in hospitals, and so many patients felt that it was preferable to be on EPREX as a means to try and spare blood transfusion support if possible. Lenolidomide is another kind of frontline treatment that we use in myelodysplastic syndrome, depending on the genetic subtype. So lenolidomide is kind of a chemotherapy pill. It is used in another blood cancer called multiple myeloma. It's an immunomodulatory type of drug that has been shown to improve bone marrow function and improve blood counts in patients with lower risk MDS. And it tends to be particularly effective in people who have a particular set of genetic abnormalities. So the genetic abnormality is called del5q. And so often in people who have low risk MDS with this genetic abnormality, lenolidomide would be our frontline therapy, and it works quite well. Most people will respond, and patients sometimes find that that it's a preferable treatment strategy because it's a pill, they can take it at home. And again, the goal is really to try and to prevent blood transfusions and keep people feeling as well as they can. And then very recently in Canada, we've started using a medication called luspatercept. So luspatercept is an IV medication that is, or an injection that's given every 3 weeks. And there was a trial that was published last year that showed that in people with, again, a certain subtype of myelodysplastic syndrome, so MDS with ring sideroblasts, that luspatercept could again help to prevent the need for blood transfusion support. And so I have a number of patients in my clinic who were started on this when the access program was open, and we were able to get them off of regular blood transfusions. And now they're maintained on an every 3 week injection. Unfortunately, right now, I think the access program is closed, and we're currently in the process of national negotiations for funding. So it's harder to access luspatercept at no cost, but that's something that we are hoping might become available to our patients again in the near future, either as a single agent or in combination with other medications. And then earlier I had mentioned that MDS is a spectrum. So those are kind of the 4 primary treatments that we often use in people who have lower risk MDS. But on the other end of the spectrum, we often employ a different type of toolkit. So in patients whose MDS is classified as higher risk, we often start with more of a chemotherapy-based approach. And so we use medications like azacitidine, decitabine, or in rare instances, we can sometimes use bone marrow transplantation as a means to control MDS. So azacitidine is a chemotherapy. It is a gentle type of chemotherapy compared to many chemotherapies that people have commonly heard of. It's given as an injection into the skin, and it's given daily for a week, and that's repeated every month. And we use azacitidine because there's been studies that have shown that when patients have high-risk MDS, azacitidine can improve blood counts and it can prolong survival amongst patients who respond. And so I would say currently in 2022, azacitidine is one of our mainstays of treatment for patients who have higher risk MDS. The problem with azacitidine, or one of the less desirable aspects of azacitidine, is that it requires an injection. And the stability of the drug means that it needs to be given in a cancer center. So it's not something that people can self-inject at home. And so it's logistically can be very challenging for people who don't live close to a cancer center or who don't have the means or the ability or even the desire to come to a cancer center that often. And so there's been a lot of enthusiasm to develop oral options for patients to try and mitigate that limitation. And so Inqovi is one of the newer medications that we've been gaining more experience with in Canada over the past couple of years. And it's very likely to be how we routinely administer therapy in the future. So decitabine is kind of a cousin of azacitidine. It's a chemotherapy drug that works very similarly, but it used to need to be given in the IV. And so over the past few years, they've combined decitabine with cedazuridine, which alters the metabolism of decitabine and now allows it to be given as a pill rather than as an IV injection. And so the benefit of this medication is really convenience. So this is an oral medication that's taken once a day for 5 days, and then that's repeated every 28 days. And so people often like this because it works similarly to azacitidine, and yet it can sometimes alleviate the need to go to the cancer center or to the hospital as regularly because you're not going for those injections. And so Inqovi was being used quite frequently, actually, over the past year across Canada through an access program. And the access program has closed, and now again, we are in the process of undergoing funding negotiations across the country, and we're hoping that Inqovi will be readily available to hopefully most patients with higher risk MDS who need chemotherapy. And then I didn't want to talk about this in too much detail, but bone marrow transplantation is also an option for some people with higher risk MDS. So bone marrow transplantation is sometimes advantageous because it's really the only therapy that offers prolonged disease control. There's a lot of therapies that we use that can manage cytopenias and that can improve bone marrow function, but it will never really get rid of the MDS for good. Whereas bone marrow transplantation can sometimes have that opportunity to do so. But as many can imagine, it does come with the risk of increased toxicity and morbidity. And so it really does need to be carefully considered in terms of patient age and their likelihood of tolerating a bone marrow transplant, but also very much so their preference in terms of whether or not that's something that fits with their goals and their objectives, because it is definitely a much more intensive therapy compared to many of the other therapies that we've talked about thus far. And so keeping kind of that background in mind in terms of what the MDS treatment landscape looks like right now, there are a ton of novel MDS therapies that are currently underway and that are being investigated, many of which will hopefully, come to practice in Canada in the somewhat near future. And so many of these therapies are targeted therapies. So instead of using, kind of a broad brush type of chemotherapy drug, we're now looking at the pathophysiology of MDS and how different MDS cells function different than other types of blood cells. And then we're developing targeted drugs based on some of these abnormalities or some of these processes within the cell. And so here we have in kind of blue and purple is a picture of a cell. And then in kind of these yellowy orange ovals, we have different surface markers or transcription factors that we have used here to highlight how there's drugs that have been developed to try and target kind of some of these processes. So this isn't necessarily meant to be something that we're going to go through in a lot of detail. And I know it's really small and many of you might not be able to see it, but I wanted to try and put the entire slide there because this is really a list of ongoing clinical trials that are just looking at targeted therapy in MDS. And so the name of the game really is to use kind of commonly used backbone drugs that we use regularly in routine practice, whether that's Inqovi or azacitidine, and then pair them with other drugs, whether that's a targeted drug or an immune therapy, to try and see if that combination can help to improve disease control and improve blood counts and help people live with their MDS for longer periods of time. And so I don't know how many there are here, but there's definitely well over 10 targeted therapies that are currently under various stages of investigation. And the two that I wanted to kind of highlight here with the red box, one is the Ascertain study. So that was the phase 3 trial of Inqovi. And then the other one is the Verona study. So the Verona trial is something that I'm excited about. And some of you may have heard about it through clinical trial opportunities at your local center. So the Verona trial is currently still enrolling, but is likely to complete soon, like within the next few months, and is anticipated to have some preliminary results within 2023. So it's pretty far along in terms of the investigative process. And the Verona trial is specific to patients who have higher risk MDS, and it's looking at azacitidine, which is currently what we would typically be using, versus the combination of azacitidine with venetoclax, which is a chemotherapy pill. And this combination is actually what's currently used in the frontline therapy for patients with AML, although there's some modifications in terms of how we're going to use it in the MDS group. And I think there's a lot of hope and expectation that the results of the Verona trial will really shake things up and modify what our frontline approach is for patients who have a new diagnosis of MDS. And I anticipate that it will likely become our standard of care within the next couple of years. This is another table of different trials than the table that I had highlighted before, except instead of focusing on targeted therapies, this is instead focusing on various immune therapies. And it's hard to envision how we could possibly have a table of trials that are looking at immune therapies, but we're getting pretty nifty in medicine, and we're evaluating a lot of cool things. And so immune modulatory therapy is again likely to have a prominent role within MDS in the next few years. And so the trial that I wanted to focus on was the magrolimab trial, which is a phase 3 trial, so it's fairly advanced. It's called the ENHANCE trial. And the ENHANCE trial is looking at azacitidine versus azacitidine with magrolimab, which is a monoclonal antibody. And magrolimab is really cool. It modulates the immune system in such a way that it allows your immune system to more readily detect the MDS cells and kind of eat them. So it modulates the don't eat me signal. And so instead of allowing the aberrant cells or the cells that aren't working properly to escape the immune system, it kind of brings them right to the forefront so your body can find them and get rid of those cells. And it's another way that our body can sometimes use to improve disease control. And so this is, again, another phase 3 trial. So it's gone through all of the preliminary investigations, and a number of various small trials have been done, and it shows very promising results. And we're hoping that, that we'll see some positive results from the phase 3 trial that are anticipated to be reported within the next year or two. And so I want to summarize by saying that there's a lot of novel research that is evaluating different therapies in MDS. There are tons of clinical trials. Many are kind of early in the stages of drug development. Some have progressed to phase 2, where we're doing smaller studies to make sure they're safe and well tolerated. And some have even progressed to phase 3, where we're kind of doing that final evaluation to compare to what we're currently doing and make, to really get a better understanding of if we can improve things through modifying the treatment strategies. And so I think that the management for MDS will change a lot within the next few years. And I think that's an exciting time for care providers and hopefully an equally exciting time for patients as well. There are various clinical trial opportunities across Canada, and that does vary from site to site. But what I hope to see is enhanced clinical trial opportunities and participation across Canada so that we can provide more clinical trial enrollment opportunities to patients with MDS who are interested. And so that's an area of active interest for myself. And so I think that's where I wanted to leave that for now, but I'm happy to take any questions if anybody has any questions about anything we talked about.